Welcome back, guys. Now in this video let's discuss about pancreas. Okay, see, we all know pancreas have two important functions. The first important function is the exocrine function. Okay, so exocrine function, we all know what is exocrine function. Exocrine function is the production of enzymes. Okay, so exocrine function is the production of enzymes like pancreatic enzymes. Okay, pancreatic amylase, chymotrypsinogen, trypsinogen, procarboxypeptidase, pancreatic lipases, colipases, all these enzymes which are helping in the digestion of food. So this is the exocrine function. So exocrine function is production of enzymes, and those enzymes are going to help in the digestion of the food. See, these enzymes are not going to be released into the blood. Okay, enzymes are released into the gut. They will help in digestion of the food. Now what is the other function? The other function of the pancreas is endocrine function. Okay, so what is this endocrine function? Endocrine function is the production of hormones. Okay, it's the production of hormones. Now which hormones, sir? See, in the pancreas there are different types of cells present. Let me show you here. See, there are different types of cells present. For example, like alpha cells. Okay, alpha cells are A cells, beta cells are B cells, something like that. Okay, so alpha cells are A cells, beta cells are B cells, delta cells are D cells, F cells, and epsilon cells are E cells. So these are the different types of cells present in the pancreas. Okay, now these different cells, they will produce different types of hormones, and those hormones are going to show different actions in our body. Okay, now let's see what are the hormones which are produced from the alpha cells. So alpha cells of pancreas, okay, alpha cells of pancreas are going to produce glucagon. Okay, so glucagon is getting produced from the alpha cells. Now the beta cells are going to produce insulin, and delta cells or D cells produce somatostatin, and F cells produce pancreatic polypeptide, and epsilon cells or E cells are going to produce hormone called as ghrelin. Okay, so these are the different cells producing different types of hormones. Now let's see what are the functions of these hormones. See, glucagon, what it will do? Glucagon is going to increase the blood glucose levels, but the beta cells, by producing the insulin, what it will do? It will decrease blood glucose levels. Okay, so blood glucose levels are decreased by insulin. How it will decrease? Later we will see. But insulin produced from beta cells of pancreas decrease the blood levels of glucose. Glucagon produced from the alpha cells of pancreas is going to increase the blood glucose levels. So remember, like glucagon. So glucose gone. Okay, glucose gone. Whenever the glucose levels in your body goes down, whenever the glucose is gone, who is going to be released? Now your pancreas will release glucagon. Now what this glucagon will do? Glucagon will increase the blood glucose. See, already you are having the less blood glucose. Okay, glucose gone. So in these conditions, whenever you are having hypoglycemia, during these hypoglycemic conditions, the alpha cells of pancreas are going to produce a hormone called as a glucagon, and this glucagon tries to maintain your blood glucose levels by increasing the blood levels of glucose. Okay, now let's talk about the delta cells. Delta cells, they will produce somatostatin. Okay, they will produce somatostatin. Now what is the function of this yeah, already we have discussed, right? It will produce somatostatin. So what this somatostatin is going to do? Somatostatin, yes, it decreases. Wherever you see the word somatostatin, statin means inhibition. Okay, see, it decreases everything. Somatostatin decreases insulin. Okay, it decreases glucagon. Okay, so both insulin levels, glucagon levels, and somatostatin in the anterior pituitary. Okay, somatostatin is also produced by the hypothalamus. That somatostatin will decrease the growth hormone production, and not only that, the somatostatin is produced in the GIT also. There it will decrease the release of gastric acid. Okay, somatostatin inhibits everything. It decreases all the secretions. Now pancreatic polypeptide is not that important, and epsilon cells are producing what? Epsilon cells are producing ghrelin. When? See, produce ghrelin, important point which I want you to know is produced during, okay, produced during fasting. Okay, this ghrelin is produced during fasting. And what is the important points about the ghrelin? Ghrelin increases the hunger. Okay, it increases the hunger. And the ghrelin, it will also go to the central nervous system. In the pituitary gland, this ghrelin can actually stimulate the somatotropes. So by stimulating the somatotropes, ghrelin will increase the growth hormone, increases the growth hormone. Okay, so these are the important points about the ghrelin. So ghrelin is produced during fasting from the pancreas by the epsilon cells. Now this ghrelin, what it is going to do, it is going to increase the hunger and it increases the growth hormone release, Okay, so these are some important points which I want you to know. Now after this, let's talk about C-peptide. Now you will get it out. Sir, what exactly is the C-peptide and amylin? Please look at here, C-peptide and amylin. Now if someone asks you the C-peptide and amylin, from where they are getting produced, see here. We all know, okay, a normal student knows that the beta cells of pancreas are going to produce insulin. Okay, beta cells of pancreas is going to produce the insulin. But remember, not only insulin, these beta cells will also produce some other hormones like amylin and C-peptide. Okay, amylin and C-peptide. Okay, so what are the three important substances which are produced from the beta cells? The beta cells produce amylin, C-peptide as well as insulin. Now let's talk about important points about this C-peptide. Okay, most of the student knows what are the actions of the insulin, how insulin functions. Okay, most of the student knows. Now what about this C-peptide and what about this amylin? Now let's see here. See this C-peptide. Okay, it is produced in equimolar concentration. Okay, it is produced in equimolar concentration along with the insulin. See, in order to understand this, let me tell you. See, actually, insulin is produced in the form of pre-proinsulin. Okay, pre-proinsulin. Okay, it's a precursor. Like, you know, try to understand. Like, it's like a precursor molecule. Okay, so this pre-proinsulin, okay, so it will go into the rough endoplasmic reticulum where certain changes will be happening. Like, you know, post-translational changes will be happening. So that pre-proinsulin will be converted into proinsulin. Okay, first, what do you have? First, you have pre-proinsulin. This is the first molecule which is produced by the beta cells. Now, this pre-proinsulin will undergo certain changes. It will convert it into proinsulin. Okay, proinsulin. Now, let me show you how exactly this proinsulin is there. Now, this is how the proinsulin molecule will be. Okay, see, this is how the proinsulin molecule. Now, see, all these are the amino acids. Let me show you the amino acids here. See here, these dots. Okay, let's consider them as amino acids. Okay, all these amino acids. See, insulin is a peptide hormone, right? Okay, insulin is a peptide hormone. So, even see here, all amino acids are sitting like this. Okay, even here also, these amino acids are there. Okay. Now, what I am trying to put into your mind is, see, this is exactly this molecule which I am showing you. This is the proinsulin. Now, here what do you have? Here you are going to have these sulfide bonds, which are called as the disulfide bonds. Okay. So, this is how. But after some time, even this proinsulin molecule will be converted into insulin. So, this is the real one. Okay. This is a real insulin. So, what exactly is happening? See, during this changes process, now you are going to have a cut over here. Now, this chain, okay, this linker molecule, try to understand, it's like a link. Okay, now this linker molecule got detached. So, at the end of the day, now insulin is having how many chains? Now, there will be one alpha chain and one beta chain. Alpha chain and one beta chain. Okay, now here is the cleaving point. Now, here is the cleavage. Okay, now cleaving is happening there. Now, what happens? See, this molecule, okay, let me show you like this. Now, this molecule, okay, is released. This molecule, the small part, okay, the small part of the peptide molecule is released. So, what exactly is that? That's nothing but the C-peptide. Okay, that's your C-peptide. So, now tell me, think logically and tell me, for every one insulin molecule, how many C-peptides are produced during the process of making of insulin? For every insulin molecule, one C-peptide molecule is produced. Okay, so while you are converting the proinsulin into the insulin, you are actually forming one insulin molecule as well as one C-peptide molecule. So that's why we say the C-peptide is produced in equimolar concentration along with the insulin. Okay, so some more important points if you want to know. See here, this insulin, which is made up of alpha chain and beta chain. The alpha chain is having how many amino acids? 21 amino acids are there, and beta chain is having 30 amino acids. 21 amino acids as well as 30 amino acids. In total, there are 51 amino acids. Okay, in total, how many amino acids are there in the insulin? 51 amino acids. Okay, these are some important points. Now, so what is the importance of the C-peptide? See guys, the C-peptide is considered as a marker of endogenous insulin production. Okay, it's a marker for the endogenous insulin production. So what exactly I mean by this word? Okay, marker of endogenous insulin production. See, a lot of questions will be coming from this area. Now, insulin, it will be acting on our cells. Okay, insulin do its duty. Okay, so insulin, it will act on the cells, try to decrease the blood glucose levels. Okay, so whenever there is insulin, that insulin will try to decrease the blood glucose levels. How? If insulin acts on the skeletal muscles, or if insulin acts on the adipose tissue, now this adipose tissue or the skeletal muscles, they will readily uptake the glucose from the blood. Okay, they will readily uptake the glucose from the blood. So what happened to the blood glucose levels? Blood glucose levels will be decreased. Okay, well and good. Now insulin is doing its job. Okay, after some time the insulin will be destroyed, metabolized in the liver as well as in the PCD cells of the kidney. That's a totally different story. But here see, insulin is released, insulin is doing its job. Okay, well done. But what about this C-peptide molecule? C-peptide molecule. Now the C-peptide molecules are excreted in the urine. Okay, they are excreted in the urine. Now, if in the urine, if you see 100 C-peptide molecules, how many insulin molecules are produced in the body? 100 insulin molecules. So that's why equimolar concentration. Okay, so if 100 insulin molecules are there, means 100 C-peptide molecules will be there. Okay, well and good. But why it is considered as the endogenous marker of insulin is, see, you can actually look at the C-peptide molecules in the urine. Okay, you can actually look at the C-peptide molecules in the urine. Then why it is called as the marker of endogenous insulin production? In order to understand this, okay, you need to know some scenarios, clinical scenarios. But even before going that, okay, let's talk about this point also. See, this C-peptide differentiates. See, it is differentiating endogenous and exogenous sources of insulin. Okay, it differentiates endogenous sources of insulin and exogenous sources of insulin in evaluation of hypoglycemia. Okay, now comes the question. See, how to understand this differentiates endogenous and exogenous sources of insulin? In order to understand this, let's take a scenario. Now, imagine that you are sitting in the clinic. Now you are the one who is sitting in the clinic. Okay. Now you got a case. Now what is this case? Now 55-year-old patient. Okay, 55-year-old male patient. Now with a known case of diabetes mellitus. Okay, diabetes mellitus type 1. Now he present to the clinic. Okay, with lethargy. He's almost in unconscious state. He is presenting to you. Now, you know he's a known case of diabetes mellitus, and when you look at the blood glucose levels, see, when you look at the blood glucose levels, now his blood glucose levels are very low. That is, now maybe 50 milligram per deciliter. Okay, now you are getting it out. This fellow, okay, this patient, yes, he's a male diabetic patient. Now he is suffering with hypoglycemia. Now, what is the most logical explanation? The most logical explanation is he might have taken extra dose of insulin, okay, without knowingly, by just forget, just he got forgotten that he have already taken a dose. Now, again, accidentally, or just he have forgotten and he have taken extra dose or overdose of insulin. So that extra dose of insulin is causing the hypoglycemia. This is what usually you think. But there might be other reason also. Okay, you don't know whether this patient is using insulin or not. Okay, see, one explanation is this patient might be using insulin. This patient is using excessive insulin. Okay, this patient is using excessive insulin, and that excessive insulin is causing all these problems. Okay, all this hypoglycemia and all that stuff. There might be one more possibility. What is that? He is taking some drug. Okay, he is taking some drug. Okay, drug X. Now what this drug X is doing? Again, this drug X is stimulating the release of insulin. So that drug X is increasing insulin secretion. Now, okay, so now you are having a 55-year-old male who is having diabetes mellitus. Okay, let's take here for more convenience. Now let's take diabetes mellitus type 2. That's more relevant, that's most common, and that's more relevant. See, now our patient is, yes, 55-year-old male, diabetes mellitus type 2 patient. He is having less levels of glucose, hypoglycemia is there, and he presented to your clinic. Now by looking at this hypoglycemia, okay, now you are having this one doubt. What is that? This hypoglycemia is because of what? This hypoglycemia might be because of two reasons. What are the two reasons? He might have taken exogenous insulin. He might have taken exogenous insulin. Okay, not into the IV. Anyway, he might have taken exogenous insulin. Okay, this is one cause. Overdose of exogenous insulin is leading to hypoglycemia. This is one cause. Or what is the other cause? The other cause is he have taken a drug. Okay, he have taken a drug in excessive quantity, some X drug, that have increased the endogenous insulin secretion. More endogenous insulin is released, and that is causing the hypoglycemia. So there are these two possible explanations are there, and now you need to find out, like, is it the exogenous insulin is a culprit, or is it this drug X which is increasing the insulin secretion, is it the culprit? Now how to differentiate? By looking at the C-peptide levels. Okay, by looking at the C-peptide levels. Now, see, if it is exogenous insulin, okay, if you have taken exogenous insulin, now exogenous insulin does not have any C-peptide, so the blood levels of C-peptide is not going to be increased. Okay, so if the C-peptide levels are normal means you have taken exogenous insulin into the body, and that exogenous insulin is causing the hypoglycemia. And if you look at the C-peptide levels, now if the C-peptide levels are elevated in the body, okay, now the C-peptide levels in the urine are more, which means he have taken the drug X. Okay, the drug X I am saying you, it's nothing but a sulfonylurea. Okay, sulfonylurea, or it's a meglitinide. Sulfonylureas, meglitinides, we know these are the insulin secretagogues. They increase the endogenous insulin secretion. If more endogenous insulin secretion is there means, what happens? More insulin production as well as more C-peptide production. So the blood levels of C-peptide, the urinary levels of C-peptide will be more. So this is how, yes, we can differentiate the causes of hypoglycemia. The causes of the hypoglycemia, see, okay, evaluation of hypoglycemia. The evaluation of hypoglycemia, the cause of the hypoglycemia is two. Either he have taken exogenous insulin, okay, overdose of exogenous insulin, or this patient have taken a drug which is an insulinosecretagogue, and that insulinosecretagogue is increasing the insulin release, that is causing the hypoglycemia. These are the two reasons. So how to differentiate between these two? By looking at the C-peptide levels. Okay, we are done. Now after this, let's talk about amylin. Same beta cells of pancreas are producing this amylin molecule. Now what this amylin is going to do? Okay, now this amylin, it decreases, see, it decreases glucose spike in the blood. Okay, more like insulin, right? Okay, all these are like, friends. Okay, amylin, C-peptide, insulin, all these are like friends. They act in a similar way. Why? Because they are from one single family, beta cell. Okay, they are just like brothers. So amylin, see, it decreases glucose spike in the blood. So it's not letting the blood glucose levels to rise drastically. How? Same insulin also doesn't allow the blood glucose levels to rise. Insulin decreases the blood glucose levels. Even amylin also, see, even amylin is not letting the glucose spike, which means increases the blood glucose levels. How? It maintains the blood glucose levels. How? Amylin reduces glucagon secretion. Yes, this is the way. So what amylin is doing? Amylin is reducing the glucagon secretion. So what happens if glucagon goes down? See, glucagon is the one which increases the blood glucose levels. If glucagon is going down means, okay, if glucagon is going down means blood glucose levels are also not increasing, rather increasing. Maintenance of the blood glucose. Okay, so amylin reduces the glucagon secretion. Okay, well and good. Amylin, it delays the gastric emptying, the movement of food. Gastric emptying means the movement of food from the stomach into the intestines. Okay. Now, amylin, what it is doing, it delays it, inhibits the gastric emptying, so the food is not entering into the intestines. If food is not entering into the intestines, absorption is not happening rapidly. Okay, absorption. See, if at a time food moves from the stomach into the intestine, at a time, what happens? There will be sudden spike in the blood glucose levels. Okay, why? Because at a time, a lot of quantity of food is entering into the intestines, so that absorption will happen very fastly, so that there can be a sudden spike in the blood glucose. That's, we don't want that. Okay, we don't want the sudden spike of the blood glucose levels in the blood. So, what this amylin is doing? See, this amylin, it inhibits the gastric emptying. So, only little by little amount of food, little by little food is going to enter from the stomach into the intestines. So, little food is getting digested. So, little increase in the blood glucose levels, and that blood glucose levels are going to be taken up by the cells. So, there is no sudden spike. Okay, and this amylin, it will also increases the satiety. Okay, it will also increases the satiety. Satiety means what? The feeling of fullness. Okay, I'm done. Okay, I don't want to eat any further food. Okay, it's a feeling like I'm done. So, this is something good, right? Amylin, what it is doing? It is increasing the satiety. If you have the feeling of satiety, you are not going to eat further. If you are not eating further, means no increase in further glucose levels. Okay, so amylin, by acting on the satiety center, okay, so there is something called as a satiety center in the hypothalamus, which is the ventromedial nucleus. Okay, ventromedial nucleus of hypothalamus is considered as a satiety center. So, this amylin, okay, by acting on the satiety center, it increases the feeling of satiety. Okay, done. Now, one more pharmacological integration is, see, there is this one drug, okay, amylin analog, which is called as a pramlintide. Okay, there is a drug called as pramlintide. Even in the name you can see amylin. Okay, amylin, something like. So, pramlintide. Now, what this pramlintide is doing? See, pramlintide is an analog of amylin. Okay, it's an amylin analog. It is used in the treatment of diabetes mellitus. Okay, it is used in the treatment of diabetes mellitus, especially type 1 diabetes mellitus. Okay, see, for type 1 diabetes mellitus, okay, for type 1 diabetes mellitus, the only approved drug is insulin. Along with insulin, there is only one more drug which is approved, that is the amylin. Okay, so pramlintide is an amylin analog used in the treatment of type 1 diabetes mellitus. Apart from insulin, the only drug approved for the treatment of diabetes mellitus is pramlintide. So, that's why specifically I have changed the scenario here. Okay, in type 2 diabetes mellitus, we are going to use different types of drugs. Okay, sulfonylureas, meglitinides, okay, and bicarbonate-rich, canagliflozin, like gliflozins. Okay, acarbose, different types of drugs will be used for the treatment of type 2 diabetes mellitus. For type 1 diabetes mellitus, the two important drugs, the two only approved drugs which are used is the insulin as well as the pramlintide. So, with this, we are done with the C-peptide as well as amylin. Now, let's discuss about the insulin. Okay, some important points about the insulin. Yes, we have already discussed, but some important points. Yes, we have discussed that the insulin is a peptide hormone which is made up of 51 amino acids. Okay, alpha chain, beta chain, 51 amino acids are there. This insulin is an anabolic hormone, guys. Okay, insulin is an anabolic hormone. It's not a catabolic hormone, it's an anabolic hormone. Who discovered the insulin? Banting and Best are the people. Okay, these are the scientists who discovered the insulin. And the Sanger, the structure, alpha chain, beta chain, disulfide bonds, okay, number of amino acids, the structure of insulin was discovered. The structure was given by this person, Sanger. Okay, now insulin molecule is stored along with, okay, it's stored along with which ions? See, insulin molecules, okay, let me show you. If this is the beta cell, okay, this is the beta cell of the pancreas. Now, in this beta cell of the pancreas, there are these vesicles present. Okay, these are the vesicles. Now, these are the vesicles in which insulin is there. Okay, insulin is there inside these vesicles. Now, this insulin molecule is present along with some ions. These ions are the zinc ions. Okay, zinc ions. Why with the zinc ions? Because zinc stabilizes the structure. Okay, the proper structure. The zinc stabilizes the structure of the insulin. Okay, now here let me take a time. See, the zinc. Now, when you have deficiency of zinc, it will cause a disease. Can you tell me what is the deficiency of zinc? Deficiency of zinc will cause a disease which is called as acrodermatitis enteropathica. Okay, acrodermatitis enteropathica is the disease because of the zinc deficiency. Okay, so zinc deficiency is going to cause acrodermatitis enteropathica. Guys, could you able to recollect what is the deficiency of iron causes, or what is the deficiency of iron? Yeah, deficiency of iron causes anemia, right? Simple iron deficiency anemia. Excess of iron will cause a disease called as hemochromatosis. Okay, hemochromatosis. Now, excessive Copper. Okay, copper excess of the copper in the body will cause a disease called as Wilson's disease. Okay, where you will be seeing the KF rings, okay, Kaiser-Fisher rings. Now, okay, deficiency of zinc causes acrodermatitis enteropathica, and the recent question which was asked in the exam, deficiency of selenium. Okay, deficiency of selenium, it causes 𝐒𝐮𝐻𝐫𝐞 disease. Okay, so excess copper in the body, it causes Wilson's disease. Okay, deficiency of copper causes anyone? So deficiency. So copper deficiency causes Menkes disease. Okay, copper deficiency causes Menkes disease. Okay, so with this we are done with the basics about the pancreas as well as insulin. In the next video, let's discuss about how exactly the insulin is released. Okay, step by step we will discuss. Hope the video is helpful. Thank you.